I'm gonna make a start now. Yeah. So welcome to the conference today. Today we're going to be looking at racial disparities in healthcare. We're going to be focusing on diseases that disproportionately affect Black people. So earlier on, so about last year, I started working with my university. So by the way, I go to the University of Nottingham and I'm a fourth year student, but I'm also a pre-reg because I'm on the 5-year course. So I started working with my university and we were looking at the curriculum and just everything to do with my School of Pharmacy to see how it can promote racial inclusion. And one of the things that I discovered was that there was a lot of gaps in our curriculum regarding things that we were not being taught, or when we're being taught them, they weren't being explained explicitly to cover some of these disparities. So this conference is just going to be looking at a few diseases that disproportionately affect Black people, and hopefully be able to learn why they do that, why they affect them differently. You're able to know about the diseases as well, because I don't know a lot about these diseases, so I'm hoping to learn as well. Just a bit of housekeeping. I know all your microphones are already muted, but if they become unmuted for some reason, just keep them muted. There is a Q&A box on your screen somewhere where you can post questions. Some panelists will be having their questions within their session and some will have it towards the end, but I will let you know as we go along who's doing what. And then I will be emailing a certificate of attendance at the end of the conference. So I'm hoping today that you'll be able to, as I said, learn about some diseases that, or conditions that are not usually spoken about, and then you'll be able to see how they disproportionately affect Black people and learn why they disproportionately affect Black people. So it's been good to ask loads of questions. The speakers are here for you and they've made wonderful presentations. Hopefully you'll be able to learn a lot of things. Obviously we're virtual, so you can't see a lot of people that are here. I don't think you can see anyone. So it'd be good to just tweet about the event, hashtag BPSA 2020, just to be able to meet other people that might be at the event. I'll be keeping an eye on tweets coming in and retweeting and sharing and stuff. This conference is being recorded and it'll be uploaded to our YouTube page at some point. Okay, so if you have any questions at any point during the conference, just send me an email. That's my email address and that's my name there. Or you can put it in the chat box if you wanted to. So this is the program. Our first speaker will be talking about lupus and she'll be coming on in a minute. If you can't hear her or something, just let me know and I'll be able to fix that up. Okay. So we've got about 3 minutes before we start. I don't think I've missed anything out. Got about 3 minutes before the first speaker comes on. Okay, so Shakita, do you want to share your screen then? And we can start with you.
Mason, do this for me. Okay, you ready? Mason, don't go anywhere. Are you ready? Okay. All right. So, hi everyone. My name is Shakita Jones. I want to first and foremost thank God for this opportunity to share my story, and also thank all of you for attending. And so let's begin. So my organization is called Lupus Warriors United. So today I'm going to be talking about lupus, systemic lupus in particularly. So my story begins like this. As you can see on this first slide, there are pictures of me as a young woman, young mother. Here in this picture, I have my son who is now just turned 20. You see me here just living my blessed life, enjoying life, hanging out with my friends and my kids, and just living. And then in 2011, after going out, um, after going out with my cousin for about a month, my cousin was in town and she wanted to go out dancing just about every night. So I went with her. After a few times going with her, I felt like I had the worst case of the flu. And I also had a spot on my nose, which I thought maybe I had scratched myself and didn't notice it. So I have this case of the flu. I'm thinking it would just go away. And eventually it did go away. I didn't pay any attention to it after that. Um, but moving forward to 2012, those flu symptoms came back. And I went to doctors. Doctors really didn't give me any suggestions about what it was, besides saying that maybe I was depressed, maybe I have anxiety, maybe it's just a bad case of the flu again. And so each time I went to, excuse me, just one moment. Each time I went to, is that her? Okay. So each time I went to the doctor, they never gave me a diagnosis of anything that had to do with lupus. In fact, I never even heard of lupus before. So in 2012, I became very ill. And let me back just a little bit. So before the flu-like symptoms came, I had been diagnosed by doctors as having a mental illness. And so whenever I would go see a doctor or complain about anything, they would just always say, I'm depressed, take some more medication, you're having anxiety, maybe you need a massage, maybe you need to relax because you're a young mother, you have a lot on your plate. But because of my social economics and the fact that I didn't have the best medical insurance, I was overlooked so many times. In fact, each time I went to the doctor, I was just dismissed. Um, Back again in 2012, I had severely gotten ill one day, just woke up. I couldn't breathe. Um, I went to the emergency room and I let them know that I couldn't breathe. But by the time I got to emergency room, um, my vitals were fine. I developed, so I also began to faint. They didn't have any reason for why I was fainting. I was a mom who was very active with her children. I was in college. I worked. I had a life, but once I got lupus, all of that just went out the window. Finally, I was diagnosed in 2012, and the way I was diagnosed was because my skin started to change. Had my skin not changed, they wouldn't have listened to me. Only God knows what would have happened to me. So in these pictures, these are pictures of me once I became very ill with lupus. They couldn't explain to me why I got these kind of marks on my skin. They just told me that it could have happened from the sun, but they never really told me. But when I did get a diagnosis, the way I got a diagnosis was I had gotten a biopsy done, and the doctor told me that you have lupus. He didn't explain to me what lupus was. He just told me you have lupus now. Don't go in the sun, wear heavy clothing. Like I said before, I didn't know anything about lupus. Come to find out, my aunt had passed from lupus, which I thought she died from a kidney disease, but she actually died from lupus. And so I was afraid that I was going to die. It was a really, really not a good time for me to have lupus because I just had so much going on in my life at the time. So these are some pictures of me, um, me and my children in the hospital. The picture on the right is a picture of me having a flare. Once I got my diagnosis of lupus, I began just a very, very deep depression. And my whole life had changed. My face had changed. My whole body had changed. And doctors didn't give me any hope. They couldn't even tell me why. I just wanted to know why. Why did this happen to me? And when is it going to go away? It was very frightful. I was in and out of the hospital. In fact, I lived in the hospital for a few years. So once the spots came, they went from pink to pitch black. And that was very devastating. So imagine being a young woman, active, and, just living your blessed life. And then you go from looking like this to like this, and no one can give you answers. Um, yeah, my skin, it turned pitch black. So now I'm gonna talk to you guys about what lupus is. So the Lupus Foundation of America estimates that there is 1.5 million Americans, at least 5 million people worldwide who have some form, well, not some form, but who have lupus. Lupus can strike at lupus strikes women of childbearing age, however, many children, teenagers can develop lupus also. 90% of people who have lupus are women, the other 10% are men. And let me point out too that a lot of men are embarrassed to talk or have shame talking about lupus because it is known mainly as a woman's disease. And even in media, men aren't recognized as having lupus. So I wanted to talk about that because I have a lot of brothers that I know personally who have, well, I know a few who have lupus. So most people who develop lupus is between the ages of 15 and 44. People with lupus can experience significant symptoms such as pain, extreme fatigue, hair loss, cognitive issues, and physical impairments that affect every facet of their lives. Many suffer from cardiovascular diseases, strokes, disfiguring rashes, and painful joints. For others, there may be no visible symptoms, and that's the worst when you have no visible symptoms at all. Lupus is also known as one of the invisible disease. So a lot of times people just think you're faking it or you want attention, but people are in a lot of pain. You just can't see it. So lupus can occur in all races and ethnic groups, but it's more common and severe in African Americans or people of African descent. In fact, 3 out of 5 women who are Black have lupus. So what is lupus? Lupus is a chronic autoimmune disease that can damage any part of the body, skin, joints, and our organs inside the body. For me, it attacked my skin, which I'm very fortunate that it attacked my skin, because what you see, the inflammation that was on my skin could have been inside of my body, which it doesn't heal when it's inside of your body and you have inflammation. So it's a chronic autoimmune disease. So chronic means that the signs and symptoms tend to persist longer than 6 weeks and often for many years. With good medical care, most people with lupus can lead a full life. It says full life, but it doesn't say a life where you're functioning. It's very hard to function when you have lupus. So with lupus, something goes wrong with your immune system, which is the part of the body that fights off viruses, bacteria, and germs. Autoimmune means your immune system cannot tell the difference between these foreign invaders and your body's healthy tissue, and it goes after healthy tissue as well. So this causes inflammation and pain. It causes a lot of inflammation and pain. The pain was so severe for me that many times I wish I was dead. That's how bad the pain was. The physical pain and also the emotional pain of all of it. So people with lupus have flares, and that's what you saw in those pictures that I showed you. Some of those pictures I had flares, and so people with lupus have flares, and we also have remission, and that means that the disease is quiet. They don't know when you're going to have a remission. They don't even know how you get a remission. For me, it was God, because doctors gave me no hope. So lupus can be mild or serious, but should always be treated by a doctor. There are 4 different types of lupus: systemic lupus, cutaneous lupus, drug-induced lupus, and neonatal lupus. So this is pictures of the different kinds of lupus. Most times when people are diagnosed with lupus, you have what they call is a butterfly rash. And then also the cutaneous lupus or discoid lupus causes severe scarring on your skin and your scalp. It makes you have hair loss. And the subcutaneous lupus is when you have these like red raised bumps, not bumps, but scars all over your body. Now, the literature would say that discoid lupus doesn't cause pain, but I have plenty of friends who have discoid lupus who tell me that it does cause pain. So the symptoms of lupus, because lupus can affect any part of the body, the disease is different for everyone and no 2 people feel the same way. The most common symptoms are rashes or redness on the face, scaly rash that scars the skin, sores in the nose or mouth, joint pain and swelling, fatigue. Fatigue Fatigue isn't even the word for how tired a person can be from having lupus. I explain fatigue like this. You can fall asleep one day and wake up days later. And that's happened to me so many times where I make plans and I'm not able to follow through on those plans because I'm either in pain or I'm just physically too tired to even participate. And in the beginning, my friends didn't understand, my family and friends didn't understand, but now they do understand. So you have fatigue, you have fever, or the feeling of having the flu. And that feeling of having the flu for me is just about every day. You have chest pain when breathing deeply, unusual hair loss, usually on the scalp. As you guys can see, I'm beginning to lose some of my hair on the side. Um, and so you have pale or purple fingers or toes from cold or stress. You get rashes or you get rashes from the sun or you get sick from the sun. Like with me, I have like a 2-minute limit in the sun. That's from my house to my car, or from my car to whatever building I'm going to, because I easily get burnt now. And the sun can make me have a flare or cause me to be really sick. You also deal with depression. and memory problems. Depression, yeah, depression. I dealt with depression for a long time, even before being diagnosed with lupus. After lupus, I dealt with depression even more. Depression comes from not being able to have the life that you had before. That's very depressing. Having to depend on other people to take care of you, or always having to defend why you feel the way that you feel. Memory problems. Um, my memory for what is memory? I only remember half the things that I try to remember, but it's really hard, especially being that I'm anemic also. Anemia is one of the things that some people with lupus have. And for me, I have to have infusions every couple months. If I don't, I can die. And so also in the beginning, when I was diagnosed with lupus, when I was fainting, they didn't know why, but eventually they found out that I'm anemic, severely anemic. So some people with lupus have kidney disease, and you have problems with your blood. Like for me, like I said, I'm anemic, and so let's go on to the next slide. So this is a picture illustrating the different parts that lupus affect, your lungs, your heart, your kidneys. It also causes arthritis in your bones. Raynaud's phenomenon, that's when your fingers turn white or blue. You also have the butterfly rash thing going on right there. And let's see. So what causes lupus? No one knows what causes lupus. Can you turn that off, please? The heater. Excuse me. So no one knows what causes lupus. Scientists think that people are born with the gene to get lupus, and that something brings on or triggers the disease and symptoms. For me, I believe that even though I was living my best life, I also had a lot of stress in my life, and I believe that stress triggered the lupus that was dormant inside of me. It was causing some problems, and they didn't know why, but it got triggered, and I got full blown lupus. So some common lupus triggers are infections, certain medicine, sunlight, stress. Um, with the medication part of it, if you stop taking the medication, then the lupus will go away. So one thing that's very important to know is that lupus is not contagious. A lot of people initially, when I was sick and my skin changed and it was all scaly and bleeding, and my skin was all puffy, I've actually had people that I know look up the disease to make sure that wasn't contagious, which I understand, but it was really upsetting. So on this picture, we have two people that you may know. We have the beautiful Toni Braxton here, who one day during rehearsal passed out. And when she came to, they told her that she has lupus. The lupus affected her heart. She said in an interview that she's always tired. She feels like she has the flu. And when she's having her concerts, the way you can tell that she's tired because she points the microphone to the audience so that they can sing, you know. And then we also have the beautiful Selena Gomez. This young lady has lupus also, and I don't know if you read in the media that she recently had a kidney transplant. She became very ill, and she had to have her kidneys, her bad kidney removed, and she got another one from her best friend. So let's move on. So how is lupus treated? There is no cure for lupus, but there are medicines to help a person feel better. Because the disease is different for each person, not everyone would take the same medicines. Many people with systemic lupus are treated by a rheumatologist. People with cutaneous lupus are treated by a dermatologist. And let me explain systemic. Systemic means that it can affect any part of your body. For me, the lupus affected my skin, it affected my bones, it affected my nerves. Also, when you're diagnosed with lupus, you also have other diseases that come with it. Like for me, I have like 3 other autoimmune diseases that came with lupus. My lupus is in remission, but the Sjogren's that I have is, which is also another autoimmune disease, is in remission. So let's continue. It's very important to keep taking all of the medicines your doctor prescribed, not to stop taking any medicines without talking with your doctor first, and to tell your doctor about any new symptoms. Let me add to that. One, because of my memory loss, it took me close to 2 years to even remember every night where I put my medicine. Also, the medicine hurt my stomach so bad that I resented taking the medicine every night. Um, Many times I wasn't feeling well. I felt worse because of the medicine. I'll just put it that way. Also tell your doctor if you're taking any herbs or supplements, or if you're planning to add them to your diet. There may be interactions with medication, and we don't yet know whether traditional therapies will be helpful or harmful for people with lupus. Um, I want to point out that a lot of people, it's funny because people are funny to me, but many people believe that if you just, you know, eat a certain way, that the lupus will go away. Yes, eating a certain way does help, but it doesn't cure lupus. So if you know anyone with lupus, I would suggest that you stop telling them that. Okay, so sometimes it may seem like folk remedies such as magnets or copper bracelets are stopping pain or easing stiffness, but the truth is that the symptoms of lupus can come and go. So for the scientific studies of magnets and copper, they have not found proof that these are effective in relieving pain or other symptoms. That doesn't mean you should stop using them if you find them helpful, but you shouldn't rely on them instead of the medication that your doctor prescribed. And let me also say, because lupus affects everyone differently, everyone isn't taking the same medicine. There is one medicine that we all take, which is the hydroxychloroquine. You guys probably heard about that when President Trump declared to the whole world that if you take hydroxychloroquine, it's a cure-all for people with lupus, and it's not. What happened was, on the other hand, is that the medication price went up. Excuse me. So what happened was the price of the medication went up, and it was very hard to get the medicine. So I found myself calling many pharmacists to try to get the medication. As it stands now, they only give me a 2-week supply because of what he said, which was very irresponsible of him. So how do you know if you have lupus? This book right here in the right hand side in the corner below is a very good book. I recommend you getting that book if you know someone with lupus, or if you just want to learn more about it. So how do you know if you have lupus? There is no single test to see if you have lupus. However, I feel like when a woman, especially a Black woman, goes to a doctor and you've run all these tests on her and you still can't find out why she's having pain, then you should provide this test to see if she has lupus, especially for a Black woman, because we're more susceptible to having lupus. I would love for this test to be annually, just like how you have to have your cancer screening or diabetes screening. There's no reason why testing women for lupus shouldn't be a part of that, because um, it takes a very long time to get diagnosed, and I'll tell you more about that. But let's move on. One blood test that doctors use is the ANA test, which measures activity by your immune system against certain foreign invaders. About 90% of people with lupus test positive for ANA. However, people with other disease also test positive for ANA, and even people with no illness can test positive. On the other hand, it is very rare for a person who has lupus to test negative for ANA. And let me say, I have friends who the doctors know that there's something wrong with them, know that they have an autoimmune disease, but it's not coming up as lupus. And many of those friends want a diagnosis of something because you don't want to feel like you're crazy, especially if it's an invisible disease, especially when people are looking at you like you're just faking all this. And to get a diagnosis of anything would take such a heavy load off of someone's shoulders, to be honest with you. So let's carry on. So since so many other diseases can look like lupus, doctors use a list of 11 criteria to help tell if you have lupus. You must have had at least 4 of the 11 to have lupus. And all rheumatologists use this 11 criteria, or they should. They should either use the 11 criteria or test the using the ANA test, or both of them, to be honest with you. Because you do not have to have all the symptoms at the same time, it is very important to tell your doctor about any health problems you have had over the years. It is also important to let your doctor know if anyone in your family, parents, brothers, sisters, grandparents, aunts, or uncles has lupus or other autoimmune diseases. Like I said, I later found out that my aunt died from lupus. I always thought that it was kidney disease. I remember my aunt being in so much pain. I remember as a young girl, her wanting me to massage her and me just thinking, she's just being a big baby. But once I got lupus, the pain is it hurts to the touch. One time a doctor recommended me to go get a massage, and I cried the whole time he was giving me a massage. And it's worse than labor pain. I wouldn't wish lupus on my worst enemy. So you're probably wondering if you can die from lupus. Yes, you can die from lupus. It's believed that between 10 to 15% of people with lupus would die prematurely due to complications of lupus. However, due to improved diagnosis and disease management, most people with the disease would go on to live a normal lifespan. Let's see. Um, Die prematurely, however, due to improved diagnosis disease management. Most people will. Okay. The Lupus Foundation of America funded studies found that overall lupus was among the top 20 leading causes of death in females ages 5 to 64. Among Black and Hispanic women, lupus ranked fifth in the 15 to year old, 6 in the 25 to 35, and 8 and 9 in the 35 to 44 years of age in those groups. After excluding the 3 common external injury causes of death. So, how many of you knew that information? How many Black people even know about lupus? Of all the people in the world who should know about lupus, it should be women of African descent, West African, women of African descent. This disease affects all women, but especially women of color, and especially even more Black women. So how long does it take for a diagnosis? There are many challenges to reaching a lupus diagnosis. Lupus is known as the great imitator because its symptoms mimic many other illnesses. Lupus symptoms can also be unclear, can come and go, and can change. That is so true. Every person that I know who have lupus, who are in remission, in the back of your head, you're wondering, is this going to come back? You know, even though I have faith in the world, in the back of my head, it still pops up. You know, I've had several friends who died from lupus. The problem is that when someone dies from lupus, doctors aren't keeping track of this. And if you don't keep track of how many people are dying, then CDC isn't going to fund more money to find a cure. So you have other organizations doing their own private research. So it's important that we know how many people have lupus and how many people are dying from it. So on average, it takes nearly 6 years for people with lupus to be diagnosed from the time they first notice their lupus symptoms. I would even say it takes longer than 6 years. Um, a majority of people with lupus surveyed reported being incorrectly diagnosed. Of those reporting incorrect diagnosis, more than half of them, 55%, report seeing 4 or more different healthcare providers for their lupus symptoms before being adequately diagnosed. I can testify that that is true. Like I said, I went to doctor after doctor after doctor, starting after I had my first child, complaining about being tired all the time. They said to take iron pills, and I still would go, "You're tired because you're depressed. You're tired because you have anxiety. Take these pills." It wasn't until my skin changed that they looked further into something, to see what was going on. They didn't look further into it when I was passing out, or when I was complaining about pain. It took my skin changing for them to look into it. So I look at that as a blessing. So now let's get into racial disparities. I want you to think about, what do you think when you see Black people? Like, what are your initial thoughts when you see a group of Black people, or just Black people in general? So now let's talk about racial disparities. Racial inequalities in healthcare access and quality are varying issues as health system organization and policy barriers. The cause is complex, multi-level. There is widespread consensus that healthcare providers contribute to racial healthcare inequalities and play an important role in their elimination. I know that from personal experience that is true. From seeing doctors, the moment you walk in a room, you can tell how someone sees you or their thoughts towards you, to be honest with you. This is from my own personal experience. In response, healthcare systems such as Kaiser Permanente and the Veterans Health Administration, state and federal agencies and professional organizations have developed an array of training activities and programs for healthcare providers. For example, the Office of Minority Health recently released enhanced national standards for culturally, and I'm not going to even try to pronounce that word, services in health and healthcare, which are supported by e-learning programs and communication tools. The Med portal offers a host of online programs for providers on unconscious bias, disparities, awareness, and culture competence. Understanding providers' belief about healthcare disparities, particularly their causal attributions for disparities, is important because if providers do not see themselves as potential contributors to disparities, they may not see themselves as part of the solution to it, to just get rid of the disparities in their practice. So one thing I wanted to discuss with this is that racism is a factor that prevents Blacks from having the best health care in America. Here are a few examples of how this is how how we as Black people face discrimination on a daily basis. One, I mean, you can be unfairly fired, unfairly stopped by the police. They don't have to give you a reason, they just stop you. But discrimination also occur in more minor and subtle ways. It's the everyday discrimination. Um, you're treated with less courtesy than others, or you receive poor services in hospitals or restaurants. You're dismissed or overlooked. You're looked down upon or given no respect. People act as if they're afraid of you. If you're a Black person, I'll be curious to find out if you ever experienced those things. Um, Research has also found that higher levels of discrimination are associated with an elevated risk of a broad range of diseases, from heart disease to cancer to lupus and even premature death. These are just a few examples of discrimination and health disparities, but it's well documented that Blacks and other minorities experience a far less better treatment in every system that's in place in America. So this, I want you throughout as I talk about disparities, just what are your initial thoughts when you see a picture of with her baby or these young Black men? So this study is grounded in a conceptual framework of causal attributions based in social psychological research, which indicates that individuals' causal attributions for problems are important contributors to their belief about solutions. In particular, causal attributions has essentially important role in Bernard Weiner's theory of social behavior. His model shows that people respond to an event by judging its causes, which then contributes to the level of responsibility they assign, the type of emotional reaction they feel, and their ultimate response. When people perceive the causes of action to be within individuals, for instance, rather than the social or economic environment, Winner's theory suggests that reactions to them would be more punitive, whereas a more sympathetic, helping response results when people perceive the causal attributions to be not under an individual's control. Um, there was many times when I went to the hospital and doctors refused pain medication. In fact, they treated me like I was an addict. They want to know what wasn't I doing at home? What wasn't I doing at home that made me have to come to the hospital? And personally, I have the right to come to the hospital. It's on record that I have lupus, and I have the right to come to the hospital, and you know that I'm in pain. And I shouldn't be questioned what I didn't do at home that brought me to the hospital, because I only come to the hospital when I'm in severe pain. And so applying this theory to providers, then if providers perceive that racial healthcare disparities result from factors internal to their patients of color, they may be less inclined to feel that they have a responsibility to address disparities than when they perceive the cause of those disparities to lie with healthcare providers in a larger healthcare system. One thing that healthcare providers have to stop doing is assuming that Black people come to the hospital just to get high. Even with it being documented that I have lupus, I still was denied medication. I've even had doctors, one doctor told me he wouldn't give me the medication. Only way he would give me the pain medication is if I had a broken leg. Who is he to say how much pain that I have? In this country, they believe that Black people can tolerate pain more than other people. This is documented that they believe these things. So Researchers for decades have studied and found that if you hold a negative stereotype about a group of people, that subconsciously you're going to think the worst of these people and discriminate against them. So I want you to think about white people and your thoughts towards white people. What are your thoughts about when you see white people versus your thoughts about when you see Black people? This is important, I feel, for you to think about this if you're going into the medical field. So here we have a lovely white family with happy smiles. And you have, looks like, a woman with 2 children. I'm assuming they're her children. Maybe she's homeless or in a shelter, or I don't know. But what are your thoughts about her versus your thoughts about the Black people? I know maybe you have negative thoughts about them and positive about the Black people, or vice versa, but it's something to think about. So, past survey evidence demonstrates that providers tend to consider patient factors as more important contributors to racial differences in care than provider factors, such as their bias and their poor communication. This reluctancy to identify providers as playing a role in causing disparities is concerning because, as mentioned above, the workforce is an important target for disparity reduction efforts. And, you know, once I started doing this research, it really hit me that it does start with the care provider. It really does. It starts there. And it just really honestly blew my mind because I never thought about starting there. I just saw it as America, even though I've been discriminated against when I go to the hospital on many occasions. I've been discriminated against. I've been stopped by the police for no reason at all. I never looked at it as an individual thing. I looked at it as a whole society, but it really does start on an individual level. Okay, let's continue. However, most past research exploring provider attributions of causal factors has been, I'm sorry guys, I'm not going to even try to pronounce these next 3 words, but approaches may provide greater insight into providers' perspectives and their interpretation of the meaning of causal attributions than can structured surveys. Okay, and all this is saying is that, providers need to look inward in how they see their patients. They need to check their attitudes before the patient even come in the hospital. So in social institutions, we can look at residential segregation by race, which has led to Blacks and whites living in a totally different living situations in America. It's a classical example of institutional racism. In America, residential segregation creates racial inequality. In America, where you live determines how well education you're going to get, your employment, housing, and even access to medical care. In America, also, the way Blacks are seen on media, it shows images of Blacks not in the best light. It literally creates and contributes to both institutional and individual discrimination just by the stuff that we see on TV, what they show about Blacks on TV, or the lack of not having any people of color in your life, if you're white, So, so in America, cultural images of Blacks literally creates and contributes to both institutional and individual discrimination. So Blacks aren't only being discriminated by white doctors, but they're also being discriminated by foreign doctors who come to America to study, and they also don't have any interaction with Black people, but what they've seen on TV in their own country, which isn't always in the best light for Black people. What about Black people? Okay, so let's move on. So let's talk now about the Black mistrust in the medical community. Excuse me, let me just drink water. Okay, so what time is it? 12. Okay, so let me speed this up. So Black mistrust in the medical community. Many Black Americans do not trust their healthcare provider to act in their best interests. Research has shown that Blacks are much less likely to report trust in their physicians and hospital, thus are less likely to seek treatment or complain with recommended treatment, or they complain with the recommended treatment plans. The medical community should care about this collective sense of Black distrust in medicine, as it is a major factor in the well-documented health disparities between Blacks and whites. In many cases, when Blacks have the same diseases as their white counterparts, Blacks are much more likely to die sooner. So we can all say that in medical school, racial disparities aren't even really discussed. Racism is ingrained in every system in America. And many Black Americans do not trust healthcare providers for good reasons. And here is why. Okay, let's go back. So trust is not only a foundational element to a therapeutic doctor-patient relationship, but also is a vital factor in patients' decision-making to seek help early before diseases advance beyond treatment possibilities. In order to address this distrust of the U.S. healthcare system, there must be an exploration of the historical roots and how prejudice operates in the modern medical context. A historical perspective, the U.S. medical establishment has a long legacy of discriminating and exploiting Black Americans. Yes, they do. Historically, Black people were, I wouldn't even use the word mistreated. It was horrific, the things that they did to Blacks. So historically, medicine has used Black bodies without consent for its own advancement, while medical theories, technologies, and institutions were used to reinforce systems of oppression. So in this picture, we have a young Black slave, and we have this man named James Marin Sims, who is also known as the father of not genealogy, I can never say that word, gynecology. And he's a controversial figure because he's a controversial figure for the ethical question raised in developing his techniques. He perfected his surgical techniques by operating on enslaved women without anesthesia. So imagine, I can't even imagine how those women were treated. In America, we have a statue of this man, and we call him the father of gynecology. Why are we honoring people who treated Blacks this way? And that could tell you a lot about America. So now we're going to talk about the Tuskegee experiment. So the Tuskegee syphilis study, where hundreds of Black men without their consent were intentionally administered syphilis and denied treatment, became the very embodiment of the way medicine and medical research was weaponized against African Americans. Scholars have written for decades about the Tuskegee experiment, symbolizing the racism embedded in medicine and laying the foundation for the Black community's distrust of physicians and research. Many scholars agree that although the Black distrust of this health system started way before the Tuskegee, excuse me, guys. This study has become the central metaphor and focal point to explain Blacks' distrust in medicine and public health. So in this experiment, a group of researchers wanted to gather some Black men together, and they wanted to see how syphilis would affect these men. And they kept this study going for 30 years, even though they knew that penicillin was the cure for the syphilis. They just allowed these men to suffer. And it continued, it was from 1932 to about 1972. So it was 30 years that they let these men suffer. The research only ended when they were found out. You know, so you look at this picture here, this man knows fully what he's doing to these Black men. These Black men were probably uneducated, couldn't read, you know, probably their parents probably were slaves. They probably was, you know, cotton workers, you know, so they were very uneducated. Um, so what can be done to make changes? The medical community must address the real sense of suspicion, distrust that is deeply embedded in the Black collective memory. Earning a patient trust is a very difficult feat given these historical forces, but medical education system, hospitals, and physicians themselves can stop to address this issue. First, physicians, hospitals, and schools can address the role of implicit racial bias, which is often described as activated and often unintentional. Implicit racial bias has proved to be a powerful validated tool to help explain healthcare disparities. For instance, in one study, doctors who were found to have higher levels of implicit bias were more likely to withhold treatment from a Black patient. The schools of medicine can do its part in ensuring doctors are properly trained by integrating the concept of implicit bias into the medical education curriculum. Healthcare organizations should also offer training to healthcare professionals to address implicit bias. So, let's just talk about some of the things that actually, how am I for time? Okay. So it must be acknowledged that gaps in healthcare disparities results from a myriad of other social determinants of health, such as education level, employment, housing, community resources, and healthy eating. For this reason, holding policymakers accountable for ensuring universal equality to a variety of social resources will prove to be effective at improving the health of Black communities as well. Okay, let's go on to, okay, so efforts to improve the health outcomes for Black Americans must acknowledge the brutal history and shadow cast from decades of discrimination and the resultant collective distrust within the community. As President Bill Clinton once apologized, we cannot be one America when a whole segment of our nation has no trust in America. I just want to read some stats to you guys. Let's look at the current healthcare disparities and let's compare Black Americans to white Americans. In the United States today, you have a higher rate of disparities if you're comparing Black Americans to white Americans. If you're Black, you have a higher rate of the following compared to whites: higher blood pressure, diabetes, stroke, lupus, an inability to find a healthcare provider due to cost and obesity. You're also less likely to have your pain taken seriously in both acute and chronic events, which that is something I experienced, as I told you guys, when I went to the hospital and the doctor refused to give me pain medication. Blacks 18 to 49 are twice as likely to die from heart disease versus whites. Blacks at any age are twice as likely to die from any disease from any cause. Blacks are typically offer about 1/3 less preventative healthcare screening for like lupus or cervical cancer, diabetes, pediatrics and women health. Infant deaths are twice as common with Black babies as white babies, and Black mothers die twice. Black mothers would die twice. Oh, sorry, guys. Black mothers are twice as likely to die in giving birth than white mothers. And what this all boils down to is that Black people are actually afraid to go see their doctors or go to the hospital or go to clinics because we know the discrimination that we have to face. My mother is 60 years old, and she was the last generation that had to deal with segregation. So it's not that far away. Um, and you guys, I'm sure you've seen on TV all the racial tension that's going on in America. And I personally believe that as Americans, we need to start telling the truth about what happened to Black Americans' ancestors and what continues to happen. And then I think we can build trust that way eventually. But I don't know. I'm not, honestly, I'm not, maybe my great grandchildren. So my final words is this. Even though I have lupus, it's been also a blessing to me because it entered a lot having lupus. I learned that the things that we often worry about are so petty. I learned to appreciate the times with my family, appreciate times when I'm not sick and I'm able to go out, or I can just have a day where I have no pain. I appreciate the smallest things like butterflies, ants carrying food to their ant hill wherever they go. Because at one point I had no energy, and I would see an ant just walking across my windowsill, just as happy as an ant can be, but I couldn't move. I couldn't do anything, and I was a little envious of an ant. And I prayed to God to deliver me from lupus. I couldn't imagine my life the way it was when I was severely ill. God blessed me to come across coconut oil, and I started using that on my skin, and it healed my skin. And doctors, even to this day, always ask me why, what did I do differently? Because they told me I wasn't going to get better. I even used a walker, I used a cane, I couldn't drive myself, I couldn't give myself a bath. And I tell them that it's my faith in God. That's what healed me. Um, Even though I still have lupus, I walk in my healing, I talk healing, I believe in healing. And this last two things I want to say. I also got into modeling for many reasons, but one reason is I wanted to face any fears that I may have. And I got into modeling, and I love modeling. It's something that I've always wanted to do. And my story in my life inspires people all over the world. You can find me all over social media. Lastly, I want to say that I started my organization, Lupus Warriors United, because in my own community, there was no awareness about lupus. And so I wanted to give back to my community. So I go to different organizations, and I give them information about lupus. And I do this free, and I do it from my heart. And with this organization, I also one day want to help people get their medications. Like in Africa, you know, they don't know a lot about lupus, and many people have lupus there. I have friends who have lupus there, and they think you could just pray it away, or you can take herbs, or your family disown you because you're a burden to your family, and that shouldn't be. I have friends who are in Nigeria who can't afford their medication. I want to be a resource, not just in my own country, but like I said, in Africa too, where I can help people get their medication, and I can help people in my own country because I know people who have lupus who can't get their medication, and that shouldn't be, not in America, one of the most richest countries in the world. So that is the end of my presentation. These are some of my pictures from my photo shoots, and I'm very proud of myself. I'm not saying that in a bragging way, but I'm saying that in a way that I am proud of myself. So this is my story. I hope you all learned something from it. Thank you for listening to me.
Thank you very much, Shakita. I really enjoyed your presentation. Thank you for sharing your story. We did have a few questions come in during whilst you're speaking, but I'm conscious of time. So I will just
a little bit.
Yeah, I'll just send you the questions and have you respond to them later on, just because we need to move into the next speaker. That's okay. Yeah.
Hello, Adana.
Hi, sorry, I was trying to work my screen out.
No worries. I wasn't quite sure whether you're still having the comfort break.
I know we're running behind time, so if you needed a break, you can take one and just pop back in whenever. We're just going to move on swiftly to Charlotte's presentation.
No worries.
So Charlotte's going to be speaking to us about health inequalities in sickle cell disorder care. Charlotte's done a lot of work with the UK Sickle Cell Society. She's an advocate for it, having lost a few people to it. And she's just going to be talking to us about the awareness, what to look out for, and all of that. So yeah, just pop any questions you have in the chat and she'll answer it when she's done with her presentation. Okay, so I'm just going to let you share your screen now, Charlotte.
Okay. So just check in, you can actually see my screen?
Yes.
All right, and you can hear me properly as well?
Yes.
Excellent. And so just to let you know, I am using the headset because of the audio in my room here. So thank you very much for the invite. Thank you very much for the introduction as well, Adana. And as Adana mentioned, my name is Shola Onilari, and I'm here on behalf of the Sickle Cell Society. We also have another advocate, let me just share it properly. And I'm just going to minimize. There's so many controls here on Zoom, so just bear with me. Excellent. I'm also going to introduce Gilda Insiagwana, who is a Give Blood member. So both of us are both volunteers for the Sickle Cell Society, and she will come on later on during this session as well. So before I go and talk about my topic for today, which is health inequalities in sickle cell disorder, I also just want to touch on about the Sickle Cell Society. Now, the Sickle Cell Society is a UK-based organization. It's a charity that was set up about 40 years ago. It was formed by a group of patients, parents, and people that care about the disease, so healthcare professionals, to really address the lack and understanding of sickle cell disease at that time. So what's happening and what they tend to be involved in is really supporting people living with sickle cell disease. They're there to provide resource and just be a help, even just talking to people living with the disease and their carers about employment and what they need to do, just where they can get the information. So that's the sort of support that they provide. They're there to lobby the MPs, and this is, something really great that this charity does, and is they're part of the Sickle and Thalassemia All-Party Parliamentary Group. Now, this group is there and is formed to help address and put forward issues pertaining to sickle cell disease, and they can use the MPs and be able to put this forward in Parliament as required. There are other projects that they're involved in, such as the Heritage Project, the Screening Project. But one of my favorite, which is the Children's Holiday, it's been going on for about 80 years, not 80 years, since the 1980s. And this is giving a chance for patients, for children living with sickle cell, to be able to go away, have fun during the summer, and just be able to have discussions with themselves. And there they have doctors and nurses there to care for them. And the last two points I have there, which is South London Gives and Give Blood, Spread Love. These are the blood awareness, donation awareness projects. And I will talk about that in a little bit later. And that's where I guess myself and Gilda reside. So my aim for today is to provide some information about sickle cell disorder. Then I'll touch on the health inequalities relating to these disorders, and provide you with some data, some stats, showing that disparity in this with this condition. Then I'll touch on the blood donation projects and why this is so key for people living with sickle cell disorder. And the last bit, I think, which will be probably the most exciting bit of my presentation, will be my interview with Gilda. And so myself, I don't have sickle cell disease. I am, volunteer for the society. I advocate and want to create awareness of the disease. But I think someone like Gilda, who is an advocate, who is living with the disease, will be able to provide you with a great perspective of living with sickle cell disease. So sickle cell disease, what is it? What is the prevalence? And it's a term used to describe a group of disorders caused by the inheritance of abnormal hemoglobin genes by the parents. So someone with sickle cell would inherit an abnormal gene from their parent, from one of their parents and mum, and then another abnormal gene from their father. So there are different genotypes for sickle cell, but there are some principal genotypes, one being homozygous sickle cell disease or anemia, and that's the most common. So this is where people would have, inherit abnormal HbS, hemoglobin S from both their parents. There is also sickle cell hemoglobin C disease, and there's also sickle cell thalassemia. Like I said, there are various different variants of the genotype, but these are sort of like the common ones. And sickle cell disease can affect anyone, but it's actually much more common with people with ancestors from West Africa, India, Saudi Arabia, and the Mediterranean countries. So what this diagram is showing you is just how the inheritance works. And the example I'm showing you here has where you have two parents and they have the sickle cell trait. Now, when we talk about someone having the sickle cell trait, it's actually an individual who has one single sickle gene. It's been inherited from their parents. As I mentioned earlier, as I mentioned earlier, for them to have sickle cell disorder, they have to inherit it have two abnormal genes. And in this case, you actually have just the one sickle gene. So people with the trait don't have characteristics of the disease as such. So in this example, if they have parents, both of them are AS, have the trait, there is a 1 in 4 chance of one of their children having the sickle cell disease. So the stats also show there's 1 in 76 babies in the UK alone that carry the sickle cell trait. And also you have in the UK, for example, there's 1 in 4 people with West African background that would have sickle cell traits, and then 1 in 10 of Caribbean background that would actually have the sickle cell trait as well. Okay, so with the sickle cell disease, having that abnormal hemoglobin being inherited, what does that actually mean? So hemoglobin, it's primarily responsible is to be able to bind to oxygen, and then the red blood cell actually transports this oxygen around the body. Now, in sickled cells, this is not possible. And when the O2 is released, actually what happens is once the O2, the oxygen is released, the hemoglobin itself becomes polymerizes and starts to form strands. Now, this insert on the right-hand side shows you those strands forming. And as you can see, those strands are the cause of that sickled shape. So causes the red blood cells to be sickled. This means that the red blood cells are less effective in transporting oxygen around the body. It leads to premature red blood cells destruction as well. And there is sort of like injury to the tissue. So it doesn't just affect the red blood cells as such. It also affects, so it doesn't just affect the red blood cell, also affects the tissues relating to the blood vessels. And those blood vessels, the damaged blood vessels, would mean that they could activate a cell adhesion protein called selectin, also called sticky factors. And once you have those presence of the sticky factors, those cell adhesion proteins, it causes clustering of not just red blood cells, the clustering of white blood cells, platelets. So this clustering would form blockages within the blood blood vessels. So with those blockages is then what causes those blockages is then what causes what you call vasoocclusion within the blood, within the vessels. That means that blood cannot flow freely into the blood. Sorry, blood cannot flow freely into the vessels, and it's a main characteristics of people who have sickle cell disorder. So now sickle cell disease can cause severe pain episode, and those pain episodes are due to people, due to what I mentioned about the occlusion. Those are called occlusive crises. So they can cause severe pain because, as you can imagine, blood can't flow flow freely through to different organs, to different parts of the body. So individuals will experience severe pain in those areas. There is also severe anemia as well. There's fatigue that could be experienced, and there's also stroke. And there's just so many different complications related to this disease. And over time, because of what's been experienced, people with sickle cell may experience chronic organ damage, and this could then, can also be fatal. Unfortunately, the only cure at the moment is to have a bone marrow transplant, and this is quite limited because you need to be able to find a suitable donor for these individuals. Just going to quickly go back. There was one thing I forgot to mention on this slide, and I think this is quite key. For sickle cell disease, it is actually the most common serious genetic condition in the UK. So you have 15,000 people in the UK that have sickle cell disease. Just to put it into context, just to put it into perspective, because I'm sure a lot of you will know about cystic fibrosis. Now, cystic fibrosis affects 10,000 people in the UK. So a lot of people know about cystic fibrosis, and not probably the most common genetic condition in the UK. It's actually probably the most serious common genetic condition in the world as well. Give you some other stats. In Europe, there's about 50,000. In the US, about 100,000 people who live with this disease. Okay. So I'm now going to move on to the treatment options. And when I talk about treatment options here, it's not treating the disease, it's actually treating and preventing the complications. I had explained to you about individuals having this vasoocclusive crises. So they will need, sometimes just need daily medications such as painkillers. some individuals living with sickle cell disease may need prophylactic antibiotics because they're more susceptible to bacterial infections and also other type of infections. So those are the sorts of things that they might have to take daily. Then, of course, for some, they may need blood transfusion, and I'll go through that later on during this slide. And of course, when the pain is so severe, strong pain relief may need to be administered to control the pain. One of the drugs, which I guess is licensed in the UK for the treatment of sickle cell disease, is hydroxyurea. And this significantly reduces the number of crises that individuals suffers from. And it's not available to all, it depends on to be administered to people, to individuals with sickle cell. They, for example, have to have a certain number of vaso-occlusive crises within a year. They need to review their quality of life. So it's not necessarily available to all, but this is something that is quite useful and quite helpful for some people living with sickle cell disease. So more and more people are living longer, and this is also due to improved treatments using donated blood. So before I move on to why that is important, I just wanted to touch on something which is, I guess, sort of hot off the press, and this is a potential new treatment. Now, hydroxyurea, as I mentioned, was licensed about 20 years ago in the UK. And there is now a new drug, crizanlizumab. It's been approved, but not yet in the UK, and it's there for the prevention of vaso-occlusive crises in sickle cell disease patients. So it's one of, people in this arena are very excited that at least there's a new disease therapy available. And looking at the clinical data, it shows that there is a reduced annual rate of crises by about 45%, and then the annual rate for hospitalization is about 42%. So this is statistically significant. It's good news, and as of October of this year, this drug was approved in 36 different countries around the world. The US actually approved this. The FDA approved this last year, November 2019, and the European Commission had they approved the drug in October of this year. So, we're watching this space. I know the society are in discussions with the UK drug regulators, and hopefully this will be a drug that will be available to some individuals living in the UK as well. So I had mentioned about the fact that, with the improved treatments, with the donated blood, this is helping people living with sickle cell disease. And how does this help? Now, with those blood transfusion, they are providing normal blood cells to patients. And those transfusions would help lessen that anemia because you're getting normal, healthy red blood cells. They're reducing that whole cycle of, stickiness, that clustering occurring, so ensuring that blood flows freely within the vessels. So there are two different types of transfusion. There is a simple transfusion in which you're just delivering healthy red blood cells to the patient's body. And then there is the exchange transfusion in which they're actually exchanging the patient's sickle shaped blood cells with healthier ones. Now, with this disease, it has different impacts on the individuals. And one thing I just want to mention that, individuals with sickle cell disease have, you have different form of severity. So it could be mild, it could be serious. So what one person, who's living with this disease is experienced is not necessarily the same that somebody else living with the disease would be experiencing on a daily basis. But in general, it's really important that individuals living with sickle cell disease look after themselves. So they're thinking about what they're eating. They're ensuring that they're drinking enough water. They don't, are not involved in strenuous exercises. And, they might have to restrict participation in certain activities. With what we have now with COVID, they will be classed as vulnerable individuals. And I know with lockdown, be advised to shield, especially with the first lockdown, be advised to shield and just be mindful of, not, contracting any diseases. Now, there are also psychological symptoms. So for some individuals, which include increased anxiety and depression. Now, this also is linked to them, experiencing that chronic fatigue, that pain, chronic pain and feeling of isolation. So, with anxiety and depression, this can also be affected by socio-economic factors that are frequently seen alongside this condition. So, significant number of people who have sickle cell disease have a lower than average income. So, this information is general, BAME data that's out there just on salaries. So this would definitely affect how they're feeling and not being able to live adequately, and for the it could actually affect their ability to work, their ability to go to school, to just have regular income and have and have long hospital stays. So this is all affecting them. This is all interlinking, and you add on to that stigma in some societies, in some communities, that sickle cell disease is not something you talk about. And then when you look at the wider community, there is lack of awareness. There is discrimination in how they're being treated for this disease. So many different impacts on the individual from the disease itself, and then also from a socio-economic perspective. So that's sort of the section I had on the sickle cell disease itself. I'm now going to move on to the health inequalities. And this is a definition from NHS England. So just going to leave that up there for you to have a quick read. So quite, for me, a couple of things to note. It talks about health inequalities being unfair and unavoidable. And it could just be because of where you were born, where you grew up, where you live, where you work and your age. So that's the definition from an NHS point of view of what health inequalities are. So if we were then to look at sickle cell disease, I mentioned it was a common series, one of the most common genetic disorder. And what I always find really interesting is it's actually the first inherited disease, genetic disease that there was determined about in 1949. So, more than 70 years ago. But it's a disease where there is significant unmet medical need. So there is little progress that's been made on the prevention or the curative treatment for this disease. Over a decade ago at the General Assembly, the annual meeting for the United Nations, this was a topic that was raised and discussed, and they recognized that sickle cell anemia is of public health concern, and it's something that we needed to create more awareness of globally on this particular disease. I think it was during that time as well was when it was recognized on 19th of June as that being World Sickle Cell Day. That's recognized all around the world in many different countries, just to try and create awareness of this disease. Still, unfortunately, it's a disease that does not get as much attention or funding that it requires. So what I want to do is also put things into context when we talk about, attention or funding. I had used cystic fibrosis earlier on as an example, just to show you for comparative purposes. So with cystic fibrosis, the reason why I'm using them is, it's a genetic disorder. I mentioned in the UK, you have about 15,000 people, and for cystic fibrosis, you have about 10,000 people with the disease. Now, what I just, looking at the data online, so looking at the impact report. Now, the impact report is a summary of the impacts that charity has had in the financial year. And that information available online, you can go into the Sickle Cell Society website or the Cystic Fibrosis Trust website. They have this information there for the public. It has the total income. So the total income for Sickle Cell Society is about 750,000, whereas for cystic fibrosis, similar frequency in the UK is a genetic disorder. You have 16.5 million. So you can see that disparity in similar frequency of patients in the UK, of people living with those conditions. So I'm using it for comparative purposes. I'm not saying one disease is much more important than the other. In my day-to-day job, I work in trying to get treatments for people who, different diseases. So it is important that we fund research into getting treatments for diseases. But I just wanted to use this as a comparison. So I think, unfortunately, it does mean that there is a great barrier to do with, getting funding, getting research, and just, in general with healthcare. And that is to do with race, ethnicity, and several different socioeconomic factors are also involved in this as well. So that's why with the society, and, one of their remits is, to be a voice for those who are vulnerable and those that don't, are not able to put their case forward in, to who needs to hear it, to the policymakers. So there are reports here that have shown that some healthcare providers perceive patients with sickle cell disease as drug seekers and drug addicts. Now, there's supposedly stereotypes of minority ethnic patients supposedly having a lower pain threshold, meaning they can't always, they don't get the sort of care that they need there. So this is not right. We know this is not right. This also means that they're not getting the appropriate treatment. They're having treatment delays. And in 2014, NICE, the National Institute of Health and Care Excellence, urged, I like that, they actually urged healthcare professionals to improve the care for people experiencing painful sickle cell episode. Now, the Director of Health and Social Care at that time had stated that the management of the condition was variable across the country, and there was a need to actually address these patients' concerns because the treatment was unacceptable. Those delayed them receiving pain relief. According to the standards of care for sickle cell, if somebody presents at the hospital, in an acute care setting, they should actually have pain relief be administered to them within 30 minutes, and that wasn't necessarily, the case there. So I'm going to provide some information looking at two different reviews, two reports. And the first one is was called I'm in Crisis, playing word on the vaso-occlusive crisis that's been experienced on people living with sickle cell disease. And this was a 2018 report on the education of pre-registration nurses and midwives. Now, there are reports that there were healthcare professionals lacked the knowledge of sickle cell and thalassemia, meaning that they were not able to provide effective care to people living with this disease. Now, in 2008, there was also the National Confidential Inquiry into Patients' Outcome and Deaths. Now, this was really interesting to me because it highlighted that the lack of knowledge and skill of these healthcare professionals was actually a major contributory factor to the mortality of people with this patient group. And this was due to the fact that there was just poor management of their pain, having unnecessary long waits in A&E. So what happened was they had an advisory working group that was established in May to discuss, was there really a possible lack of knowledge and skill among nurses and midwives? So this report was just, it was in conjunction with, the Nurses Union Association. There was Sickle Cell Society was involved, patients were also involved in this, being part of this advisory group. So they were just mainly focusing on nurses and midwives. And there was also looking at, whether there was any credence to the fact that, in the nurses and midwives curriculum, that lack of inclusion of understanding about the disease, was it a contributory factor to not being able to provide effective care to this patient group? So in 2018, a report was published on the lack of representation of sickle cell disease, with nurses and midwife education. And in a nutshell, the key findings were, despite updating standard of care publications, so I know there's a separate one for adults with sickle cell, there's a separate one for pediatric, for thalassemia, there was adults and children one.
For diabetes. So yeah, you can share your screen and start your presentation whenever you want. just a bit of a sound system. Okay, that's better now, yeah. Not really, no. There's just a bit of background noise. No, not really, no. There's just some background noise that's floating in and out. Say that again, sorry. I can hear you. I'm not sure about the others. But it's a bit quiet, but the background noise is not there right now. Are you using headphones?
culture. So that's basically what it was looking at, and it was actually quite interesting to find. So I'll just take you through the slides. I don't know if you can see my mouse moving, but over here there's just like an introduction of what cultural competency is. Maybe you can, I don't mind putting this up so you guys can read it later on and you can find out a bit more about it. But the objectives of my dissertation were mainly to self-examine if third-year pharmacy students understood the term cultural competency. So if this was in a sitting area, I would have asked like how many of you have actually heard of the term before and how well you guys understand it. And then the second part of it was to investigate how individual ethnicities contributed to investigate how an individual's ethnicity contributed to how they perceived and interacted with other patients from different cultures. So what that just means is like me being a Black person, how did that influence me speaking to another Black person, or me being from Zimbabwe, how did that influence me speaking to Zimbabwean patients or patients who weren't from Zimbabwe? So that's sort of like the main things that I was looking at. And the method that I used was an explorative semi-structured focus group. So I had, I believe it was about 8 students. They were all female. Can't remember why I made them all female, but I think it was just sort of trying to keep the standards the same, and they were all about the same age. They were all in 3rd year as well. So try not to have like varying different things in my study group. And yeah, I just did a focus group with them and asked them loads of different questions. They were all from different ethnic backgrounds. So I think over here you can just see the different backgrounds that we had. Obviously, that doesn't cover the multitude of different cultures that we have, but it did sort of shed some light into the questions that I was asking. So the results, which is probably the most interesting part. So let me just move this out there so I can see. So the results showed sort of themes within that things that people were answering. So there were various different themes. It's quite small in here. I'll see if I can zoom in. No, I can't. But it did show that people did understand what the term cultural competency was, which was one of the things that I was trying to assess. But they didn't really quite know how to sort of develop their understanding of other cultures. And I think even now, whilst working, that's something that I'm personally working on, and, you know, working with different people as well. You're always trying to understand other people a bit more. And I think that's something that us as professionals, as future pharmacists, we should always strive to do. So yeah, I think future studies should definitely look at how, you know, healthcare professionals can look into developing their skills for understanding other cultures. Another thing that we did see was something called reciprocal association. So a lot of the students were saying that, for example, I don't know, who can I pick? One of the Chinese girls was saying that when Chinese patients come into the pharmacy that she worked in, a lot of them would want to be served by her just because the patient, I guess, felt, I don't know, more comfortable speaking to them. They felt more attracted to them, or not attracted in a sense, but like drawn towards them because they were alike. And I don't know if many of you have experienced that where you work in pharmacies. If you see that, you know, certain cultures of people are drawn towards you, again, more investigation would have to be done into why is that, like, why is somebody like patients more drawn to like talking to healthcare professionals who are like the same background as them. So that's something that we found. And then another thing that we found, which sort of goes hand in hand with that, was ethnicity was an influencer. So our ethnicity does have an impact as healthcare professionals with how we communicate with patients. And again, it's all about self-development. And I think sort of conclude the whole dissertation, I sort of came to an understanding that, you know, I'm very aware of my culture and, you know, the people that I picked to do this study with, which would be similar with other people. Like, everyone is very aware of their culture, whether you're British, you know, Lebanese, whatever, you're very aware of your own culture. And when patients who are of the same culture come in, it's easier to communicate with them. But at the same time, just as we're aware of our own culture, we should be aware that we're not aware of other cultures, if that makes sense. So when patients who are of a different background come in, we should try make ourselves aware that they might not quite understand what we're saying because of language barrier. You know, if somebody's on hypertension medications, they might, you know, have a certain diet that's different from what our diet is. So we need to cancel them a bit more on certain things. So that's sort of like what the whole dissertation was on about and what it was looking at in terms of culture. I don't know, that's quite a quick sum up, but I don't know if anybody's got any questions or anything they would like to ask regarding it. Questions, anybody? It's really quiet, or are people typing questions like in the chat?
Yeah, I'm just waiting to see if questions will come through.
Okay.
But in the meantime, thank you. It sounds very interesting, what your dissertation was about.
Yeah, no, it was really interesting. And like I said, even now being at work, it's sort of like an ongoing development. So it'll be quite interesting. Oh, there's a few questions coming up. Okay. What were the particular challenges in getting your participants to open up to you? Yes, I think the thing with that, people obviously didn't want to come across as if they were not as racist as such, but it's different. It's difficult, obviously, to say like, oh, you know, I like serving these type of patients and don't really get on well with serving these type of questions. But I think it's a conversation that we need to have to be able to better equip ourselves as professionals to be able to serve the cultures that we don't know how to serve, because not just England, but worldwide, everything's becoming very diverse. There's so many interracial marriages going on, which just means there's going to be so much diversity 10 years from now. And as pharmacists, we need to be able to serve that diverse community. We need to be able to know what advice we need to give to certain groups, you know, what fasting periods different groups, you know, patients go into. That's all information that we need to know. So I think when I did the focus group, I was really just asking very probing questions, probably questions that made them feel quite uncomfortable. But, you know, thankfully, they all did open up pretty well, which was really good. I think it'll be interesting to sort of do the study on a larger scale, but obviously can't do that at university, but it'll be something really interesting to do on a large scale. I hope that answers your question. Is that Loretta? And then there's one from E. She says, how was the process like for you as a pharmacist? What did you think of it? Is that the process for the, like, doing the dissertation? Is that what I'm understanding? Hope I'm not prying too much, but how is it pre-reg like? Okay, so the process of doing the dissertation, I guess that's what you mean. It was okay. I think it was quite challenging and time consuming, but it's something that I was really interested in because I think it's something that's always going to be there and that's always going to affect us, like I've said. And now being a pre-reg student and working full time, I definitely see it a lot more often. And I work in community in Boots, and the area that I work in is extremely diverse. So you have all these patients coming in from loads of different backgrounds, and it really does getting to know does take getting to know the patients and asking them questions to be able to better advise them on things. So yeah, I hope that answers your question. Hi, as you said, some people would rather be served by someone of the same ethnicity/background. Do you think there's anything pharmacists can do to encourage people to talk to other members of staff or discourage this from happening so much? Yeah, so with this, one thing that I realized when I was doing the dissertation and also in practice, you can't really change what patients are going to do, but you can change your attitude as you go to, say, serve patients or go to speak with patients. You find that a lot of patients can be quite loud. So, you know, sort of like which cultures are quite loud. I hate to say Black people, but I will just throw that out there. It's a safe and open space. So Black people tend to be quite loud when they come in, and you know, that can be not something that, you know, somebody who's a pharmacist is used to. They're quite soft and toned, but you yourself just adjusting yourself to that nature of that culture can just change a lot in the dynamics of how you're communicating with that patient, or even just having a small conversation with them with something that they might have previously mentioned when they were in, just opens up sort of a knowledge for that patient. And similarly, you might have patients who are quite quiet when they come in. Like I've noticed that with Chinese patients, they're quite quiet and soft-spoken. So I try just to do the same, like when they come in, and I think they see that as a like for like, and it just really allows them to open up. So just being able to change your tone of voice, body language to different cultures can play a massive role in how well you communicate with patients, not necessarily changing yourself or the information that you're giving them, but simple things like body language and tone of voice can go a massive way to how well the patient will respond to you. Yeah. At least I think so. That's what I've been doing. It seems to be working okay. So any other questions?
The Q&A box, I don't know if you can see it.
There's a Q&A box. No, I'm not very tech savvy. But yes, I've seen it now. How do you plan to implement this once you finish pre-reg? It sounds like a really interesting topic. Yeah, I mean, it is really interesting. So I managed to get my dissertation published, and I'm hoping to sort of go back to uni and do some more research into this because it is very, very interesting. And like I've said, just with how diverse the world is becoming, you take it for granted sometimes how we communicate to patients and how, you know, diets are so different in cultures, the way of communicating is so different in cultures. It's a massive topic, but I think just taking bite sizes, so the area that you work in, if you see like it's highly populated with a certain culture, just take like even 5 minutes to speak to somebody who doesn't mind, you know, like you speaking to someone, asking them, oh, like, you know, we eat this type of food, this is what we do. It just makes you that bit more culturally aware of that area that you're working in. So little things like that, or even going onto Google and just researching a little bit about most of the cultures that you see coming into your pharmacy or into the hospital. I think that goes a long way, definitely. Hope that answers that question. What do you think people can do to become more culturally competent? Yeah, so I think that what I said in the previous question again can relate to that. So if you work in a particular place and there's loads of people for a certain culture coming in, ask questions where appropriate, you know, do your own research and just you know, change your tone, your body language as you see fit for those patients that you're talking to. Have you experienced being treated inappropriately by a healthcare professional because of your culture or race? Yes, I have done. And to be honest with you, with that, all I can say is don't take it too personally, because it's something that you're going to always come across wherever you work. As unfortunate as it is, just don't take it personally. The area that I work in, this one lady, came in and she was sort of like, oh, no, I don't want to be served by you. I don't know you. I'd only started my pre-reg, it was like a month in. And I was sort of like, oh, okay, then I'll see if there's somebody else available. And I think the great thing is that the pharmacist who was there really backed me up. And she was like, that's fine. If you don't want to be served by her, then you can just leave because everybody's busy. You don't get a choice of who you're served by. And she just left. Like, she said a few things, but she just left. So if you do end up in situations like that, don't take it personally, and hopefully you've got a team behind you that will fully support you. Yeah, we live in a world where things like that happen, but there's not much that we can do. All you can do is just leave it at work. Don't take it too personally. Yeah. How might Black or minority ethnic healthcare professionals who are dealing with or have family members dealing with similar generational trauma of racism and may have experienced some racism keep an open mind when dealing with individuals from historically racist backgrounds? Okay, that's quite a big question. And it's anonymous as well. Okay, let me just have a read of that again so I can understand what you're trying to ask here. Okay, I'm not sure what this question's trying to ask. I don't know if the person can just expand a bit more. Again, you can do it anonymously, but just expand that question below, and I will come back to it because I just don't want to answer it in the wrong way with not understanding what exactly it is that you're asking. So if you can, please, whoever asked it, just expand a bit more. I would love to answer it, but just tell me a little bit more of what it is that you're asking, if that's okay. So I'm going to say congratulations on getting your work published. Thank you very, very much. It was very exciting. Like, if anybody is doing their dissertation and their university encourages getting their work published or anything, it's definitely something that I would encourage. It's a long, boring process is the dissertation work, but it's worthwhile in the end, and it's a really good experience. So definitely do work on it. What advice would you have to give us as pharmacy students on how we can develop cultural awareness as we go through our course? So with this, I think speaking with different people in your class lecture room, that's a really good way to start. So if you hang around in a certain group, so like say all of you Black kids hang around together, all of you Asian kids hang out together, all of you white kids hang out together, which is normally how it is. That's how it was at my uni. Nothing wrong with saying that, and there's nothing wrong with that. But if you can, just take some time going to speak to those other cultures within your class, within your university class, and just really ask them, like, so what is it like? What is life like for you? That's a great place to start. I'm sure they'll be more than happy to expand a bit more on their cultures. And it's like a safe zone as well, because you're all at university. So yeah, that's a good place to start. So is there any other questions?
There's one in the actual chat box.
There's one in the chat box. Yeah, I was looking at the that one, which I've not answered, but has the person expanded on it? Just no, not yet. Okay. I don't know if I answered this one. Hi, as you said, some people would rather be served by someone of the same ethnicity background. Do you think there's anything pharmacists can do to encourage? I think I've answered that. So is there a link to your published dissertation? It sounds so interesting. I'd love to read it. Yeah, I don't know how I share stuff in this chat. Like I said, I'm not very tech savvy, but I'll figure it out. And before I leave, I'll leave a link to it as well, so you can access it.
I'm sorry. With the anonymous attendee, like you can and chat, like write about in the chat if I'm making sense of your question. Do you mean by, like, I know with for example, TB vaccines, they've historically had like a bit of a racist history in a sense of like, it's usually been given to immigrants. And so I know sometimes like white British people would use that as a sort of way of discrimination, being like, oh, you're an immigrant, you're not from this country. Do you mean something like that when it means to like healthcare professionals dealing with patients of that matter who've been through like racist incidents, or I don't know, because I'm trying to make sense of it.
Yeah, I'm trying to make sense of it as well, but not too sure.
I think what they're trying to say is, so we as Black healthcare professionals who might have dealt with the trauma of racism or may have had family members that have dealt with that, when we go into the workplace and we're dealing with patients from, say, for example, white backgrounds, how can we approach them, bearing in mind there's this trauma?
Right, okay, I understand. So sort of like two extremes coming together. So you're a healthcare professional and, you know, okay, I understand. Thank you for that. I think that does help it make sense. That's a bit of a difficult one, because I think that's not just really just to do with cultural competence in terms of patients. I think that's more a work environment as well, if I'm understanding correctly. But the best thing to do is just to talk about these things. So I think for Black people who do feel like, you know, they've experienced a lot of racism, a lot of generational trauma, and then coming to a workplace dealing with other healthcare professionals or even patients who are historically racist, it can be very difficult and very challenging. But with that, all I can say is communication is key. You might not come to an agreement, but at the end of the day, somebody is going to need to get treated. You're going to have to work as a team together to do whatever it is that you need to do. So, you know, instead of like walking eggshells, just talk to each other about it. I know my brother has been in a few situations like this. So he works as a doctor in Birmingham, and at times like patients have not wanted to get a surgery done by a Black doctor. They've not wanted him to do, you know, the assessment or whatever it is that they need the patient to do. And it's like, for him, you know, he might be that person in the Black group who feels like he's dealt with racism and stuff, and that patient is then the person coming from that sort of like the historically white racism, and it's like those two coming together. Then how do you deal with that? But like I say, just don't take it too personally. And although it might hurt, he just stepped away and said, okay, I'll go find another doctor. But again, your team has got to be willing to back you up. The other doctor was just like, you know, Andrew's the only doctor who's on ward and is dealing with this. You can either be served by him, or you can go back home and come back for another day for your assessment or whatever. So that's kind of the situation. A bit more difficult if it's work colleagues that you're working with. But again, I can't solve world peace, but communication with those things would probably be able to help, yeah.
I guess also, obviously, I come from a BME background, but I'm not Black. But I can say from what I've learned from university is that with the GPHC, if you're made really uncomfortable with racial incidents, you can complain to the GPHC and report an incident. You have the right to do that, and you should speak up about it.
Yes, definitely, definitely. There is paths to complain even within your workplace. There will be systems in place that you can go down and sort of like complain about. But I think ultimately your team should have your back, and that's one thing that I just try hone in on. Like, as you go into a workplace, even if you're the only Black person there, if you're the only Asian person there, you might even be the only white person there and it's full of Black people, you know, just make sure that your team has your back and, you know, you develop good relationships with them. Very difficult if, you know, there's those differences, but just try to communicate those things. If there is incidences that do happen with patients, they'll just be like, you know, if you don't want to get served by this person, you can go find another pharmacy to work in. It's difficult when the pharmacist is like, oh, okay, that's fine, you don't want to be served by her, don't worry, I'll serve you, because it's almost like saying what that person's doing is right, which is obviously not the case. So yeah,
Most definitely, I agree with that.
How does one get their work published? I think for me, the university really pushed it for us. So if you are doing a dissertation and you're thinking about getting it published, ask your university. I think through library services, they should be able to tell you how you go about doing that. But the only thing is you have to be prepared to do is sort of like rewrite your dissertation, which sounds silly. But it's like they'll like it and then they'll say, want to get it published, but then you almost have to sort of like rewrite the whole thing. So be prepared to put in a lot of work for it. If you have any issues with it, you can feel free to send me an email. I'll be more than happy to get involved and help you with that. Any other questions? I think someone's talking about international societies. Also a great way to get to know other cultures. Yes, definitely. And I think the uni does do stuff like that, like International World Day, and they put out loads of food. So yeah, ask questions. Don't be afraid to ask questions, honestly. Ask loads of questions. Anything else? No more questions. We're good.
I have a question myself. So I know I study in Manchester, but I know while moving to Manchester from London, there was a big difference in sort of like demographics. And I feel like you might have been similar for your university. So I'm asking, obviously, I don't know how it must feel like for a Black person studying in pharmacy, because I know in my course there aren't that many Black students. And I'm wondering, how does it feel as a Black student studying pharmacy? Do you feel supported or not, especially with, you know, the attainment gap, the 13% gap between students, white students and BME students? So how does that feel?
Yeah, and thankfully for my year group, there was quite a few Black people in the course, which is honestly, it's not the end of the world if there isn't, but you know, whatever culture you are, it does make life easier when you've got like for like, and you've got people who are almost the same as you that you can look to. And that goes for even lecturers. Like we didn't have that many Black lecturers. Well, there were quite a few couple, but not within pharmacy practice. And I know that again can be difficult for some people because it's like you've got other cultures teaching you, but you can't relate to somebody else as the same culture as you teaching you. But with that, all I would say is don't focus too much on, you know, being the only Black person there, or focus so much on your culture. Take it as an opportunity to experience different cultures. So take it as a learning opportunity, because wherever you go work, I'm not sure which is the dominant cultures at university or which lecturers of what cultures you mostly have, but just take it as an opportunity to learn about those different cultures. Like, don't be afraid to make friends with other people that you normally wouldn't have made friends with, because honestly, you'd be surprised just what saying hi to someone and asking them a few questions, what it will do, and what bond or relationship will form from that. So that's what I can say on that.
Yeah, thank you very much. Yeah, I totally agree with that.
Yeah.
Has anyone got any other questions before we wrap up?
I'll see if I can find the link to the dissertation, and I'll leave my details as well if anybody does want to ask anything, or if anybody's got any questions about, I don't know, anything pre-reg, whatever, feel free. I'll just find that now for you. Mhm. I think this is the chat, which everybody can see.
I'm just going to share it to everyone. So I was just sending to the panelists right now, not everyone.
Oh, okay.
Yeah.
That's fine. I don't know how to send it to everyone.
There's
That's the questions and answer box.
just where you're typing, above it, there's like an arrow that says all panelists. Do you want to click on it?
All panelists and attendees.
Yes.
Is that the right thing? Oh my days. I'm so bad at this. Okay. There you go. Okay, there you go.
If you could you, Tina, do you have time for one more question?
Yes, of course, yeah.
Yeah, so I think one of the attendees has asked a question in the Q&A box saying, I will be starting pre-reg next year. How would you suggest I prepare myself? Don't think I can remember much from first year.
Okay, yeah. I wouldn't say don't worry too much about that. So right now, focus on fourth year and completing fourth year. Once you get to pre-reg, you'll see everything coming together. You almost can't prepare for it because it's something that you've never done before, to be honest, but somehow everything does come together, like whether you're doing community or hospital. I've spoken to some of my hospital friends, and honestly, once you start working and once you're working every day, so this will be your life, like Monday to Friday, going into a pharmacy, going into a hospital, you will see all this stuff from first, second, third year and fourth year just coming all together because you're constantly doing it every day. You're talking to patients every day. You're looking at drugs every day. You're looking at interactions every day. You're selling stuff over the counter every day. People are coming in with queries. And, you know, at first it's overwhelming because you feel like, oh, I don't know nothing. But trust me, if somebody comes in with a rash for 3 months every day, and it's like, you know, yeah, this person's got, you know, this baby starting off with whatever, you know, this person's got what, you treat it with this, you'll get used to it. You know, when you're dispensing prescriptions, or if you have the opportunity to check, when you're checking prescriptions, you'll start seeing the common drugs that people are on, and it will all come together. So I wouldn't worry about pre-reg, just enjoy university, because once you start working Monday to Friday, you know, long hours, it can be tiring. So yeah, and good luck with your fourth year, and I hope you get the pre-reg place you wanted. Yeah.
Yeah, I totally agree. I started my pre-reg recently, and it does come back to you because at first you think you're not going to remember, but it definitely comes back to you on the job.
Definitely, yeah.
And yeah, definitely enjoy being at uni now because yeah, the hours are very long.
Definitely, yeah.
I think that's everything. I know there's some questions coming in that I will address in a minute.
Okay.
But I think that's everything from me. Thank you very much.
Thank you, guys. Thank you.
Okay, so we've come to the end of it now. Thank you to everyone thank you to our speakers and everyone that has asked questions and engaged with the event. With the diabetes one, I'll try to get him to re-record it and post it on our YouTube page alongside every other thing that has been recorded today. So the whole session was recorded today, the whole conference. Yes, I'll try to get that on the YouTube page. Next Saturday, we have our Pen and Error conference. And the link has been shared so many times in the chat. So if you've missed it, just send me an email or just say right now so I can put it back in for you. You can also go onto our website, which I'm just typing now, to find more information about ways to get involved with us. At the moment, we have rep applications and liaison applications going out. So you might have already seen some in your emails from like from your lecturers in your uni, or just have a look on the website to apply for the position of a rep or a liaison. I'll be sending out certificates soon.